Thank you so much for coming today. And as Sarah mentioned, we're going to go into this paper that was recently published. So briefly, a breakdown on this presentation. We're going to do a little bit of introduction and background on these three compounds: ketamine, 2R6R hydroxynorketamine, and MK801. And then a brief background on NMDA receptor antagonist neurotoxicity, or what are also known as Olney's lesions. And then we're going to jump into the paper, and we're going to look at, it was really broken down to three separate studies. The first is a sex-based breakdown on the pharmacokinetics of these three compounds in rats. The second is a single dose neurotoxicology assessment of the three compounds. And the third is a multiple dose toxicology assessment of these three compounds. So to start with, ketamine is known by this audience, hopefully. And while this is an introductory slide, there are a couple points I do want to emphasize here. The first is it has had a lot of success in the last 20 years for depression and analgesia. However, it does have a number of unwanted side effects. It has dissociative hallucinogenic properties. It's addictive, and at the US at least, it is a Schedule III compound. So the doctor won't be sending you home with it. So despite all of the advantages of ketamine, it does have some disadvantages. Ketamine itself is the racemate. It's a mixture of the R-ketamine and the S-ketamine, the two enantiomers. And mechanistically, it's an N-methyl-D-aspartate receptor antagonist. Now, when these depression studies with ketamine came out, a lot of companies were very interested in it. And they thought other NMDA receptor antagonists would replicate ketamine's antidepressant effects in humans. Various compounds were looked at, including memantine, lansamine, circ-301, and so on. And to a large extent, they failed to replicate ketamine's antidepressant response in humans. The one compound that was recently approved for depression, in the US at least, was S-ketamine, which is one of the enantiomers of ketamine. This got us thinking that ketamine itself is very, very broadly metabolized in the human body. To start with, it's a mixture of the R-ketamine and the S-ketamine. That gets metabolized to the norketamines, to the dehydronorketamines, and to 14 different hydroxyketamines and hydroxynorketamines. So when you're administering ketamine to a patient, it's getting broken down to all of these different compounds. Those compounds are being generated in fairly high levels. So this is out of a human trial back in 2012, where they measured ketamine and its various metabolites as they were present over time. And you can see that ketamine levels drop fairly rapidly from just under 200 nanograms per ml down to under 50 nanograms per ml in 230 minutes, while your levels of norketamine and dehydronorketamine rise. In particular, this compound here, second from the right, 2R6R hydroxynorketamine, and it's an enantiomer 2S6S hydroxynorketamine, one of these metabolites that were formed at fairly high levels that particularly interested us in our group back in 2015. We took a look at this 2R6R hydroxynorketamine, and in some work with Dr. Todd Gould and several other collaborators, it was demonstrated that it had similar effects to ketamine in several murine models of depression, including the forced swim test, where ketamine and 2R6R-HNK had similar effects, as well as the learned helplessness test, where ketamine and 2R6R-HNK had similar effects. The enantiomer, the 2S6S-HNK, didn't have those effects, and there were many, many more studies in this paper. But of those, the ones I do want to point out right here are the other ones, the drug discrimination, the self-administration test. 2R6R-HNK in the drug discrimination test was closest to saline, not to ketamine, whereas ketamine itself was closer to PCP. In the self-administration test, 2R6R-HNK was not self-administered to the rodents, by the rodents, while ketamine, which is addictive, was self-administered. What this suggested to us was that 2R6R-HNK had the antidepressant properties that ketamine had, at least in these mouse models, while not having many of the unwanted side effects, the potential psychomimetic effects or potential addictive effects. And this interested us greatly, and we really do want to pursue 2R6R-HNK as a potential antidepressant. The last compound I want to talk about today is MK801, which is a very strong NMDA receptor antagonist that was originally developed by Merck. However, it wasn't approved for clinical use due to its safety issues. Despite this, it does see a fair amount of use in animal models as to mimic psychosis, and especially it's a potent agent to induce this NMDA receptor antagonist neurotoxicity. So for our purposes for these studies, it's going to serve as a very nice positive control. Switching gears slightly and talking about NMDA receptor antagonist neurotoxicity, or what are called Olney's lesions often. In 1989, Olney and co-workers tested the neurotoxicity of PCP, MK801, ketamine, and several other NMDA receptor antagonists in Sprague Dawley rats. And 2 to 4 hours after administration, they noticed something unusual. They noticed this vacuolization, or these holes forming in the cytoplasm of the neurons. So this can be seen, and this is electron scanning microscopy from their paper, where on your left you have a normal neuron, where on your right you have these holes form in the cytoplasm around that nucleus. And this was interesting, and this resolved by 18 to 24 hours after treatment. This vacuolization would be gone. Out of our paper, we can also see this by hematoxin eosin staining. So on your left here, you have a normal control, just saline treated, the retrosplenial cortex of hand-Wistar rats. But on the right is after treatment here with MK801 at 0.8 mg per kg. And you see the small dark nucleus here shown in the neurons, but you see these holes form the cytoplasm as highlighted by the arrows around that nucleus. This is this vacuolization seen within the neurons. Now, this vacuolization certainly wasn't good, but perhaps what's even less good is neuronal necrosis. So in 1993, Fix and co-workers demonstrated that at a fairly high dose of MK801, 5 mg per kg, after 24 hours, they started to see necrosis in the retrosplenial cortex of these Sprague Dawley male rats. And this is these small, sharp, shrunken neurons here. 48 hours after a single dose, that necrosis was more present. We also demonstrated this within our paper, both by hematoxin eosin staining and by fluorojade staining. This is a much lower dose, 0.8 mg per kg in female Wistar rats. And in the H&E staining on the left, you see these dead neurons as with the pink corona on the outside and these shrunken dark nucleus. Perhaps easier to see, at least in my eyes, is the fluorojade staining, where the negative control doesn't show any of these dead neurons. But when dosed at 8.8 mg per kg subcutaneously, these bright green dead neurons do show up by fluorojade staining. So this necrosis, when being dosed with what's a fairly strong NMDA receptor antagonist, is of concern. More interestingly, there was also a sharp sex disparity when this was dosed, in that female rats, both at 70 days and 127 days old, were far more susceptible to MK801 and showed far more necrosis than the male rats. And this was also across different strains of rats, where Sprague Dawley rats showed this increased sensitivity for female rats due to this MK801 dosing. That sex disparity carried over to ketamine as well, where when ketamine was dosed subcutaneously in Sprague Dawley rats, you saw the adult female rats, and this is vacuolization, not necrosis, but these Sprague Dawley rats showed more vacuolization, and the females were more sensitive than the males. So at 40 mg per kg here, when the ketamine dosing, the females showed notable vacuolization while there was nothing in the males. There was also an age-dependent effect, where young rats at 1 or less than 1 month old didn't show any of this vacuolization. And at 2 and 3 months, only the female rats showed the vacuolization. But up at 8 months, you would see both the males and females. So this vacuolization effect had both an age and a sex-based effect. So this leads us into the 3 points of investigation for this paper. The first question is that sex-based effect a pharmacokinetic effect that is driving that NMDA receptor antagonist neurotoxicity? Or potentially is the route of administration making a large difference here in this neurotoxicity? The second question we're asking is, in a single dose administration, do we observe any of this neurotoxicity for 2R6R HNK? And we're going to do this by intravenous infusion so as to as closely mimic the current ketamine trials, which we're hoping to replicate with 2R6R HNK. We're also going to look at ketamine via intravenous administration, again, to see if we can replicate the current trials and see if there is any potential neurotoxicity. And MK801 here is serving as our positive control. And then we're going to do this again in a multiple dose administration. And this is going to be twice a week for 2 weeks. Do we observe that NMDA receptor antagonist neurotoxicity? Again, via intravenous infusion for 2R6R HNK. And this time we'll switch to IP administration for ketamine for reasons I'll get into in a second. And then MK801 is again our positive control. So when looking at this in the pharmacokinetics for 2R6R HNK within Sprague-Dawley rats, it is fairly quickly eliminated from the system, with HNK levels dropping down to the lower level of quantitation within 4 hours when dosed intravenously. And the graph here on the right is just a blown up example of from 0 to 1 hours of the graph here on the left, where we see there's a slight tendency, but it is not significant for there to be higher female levels of 2R6R HNK when compared to male animals. It's trending again, but it is not significant. Ketamine, when dosed IV, again shows this fairly rapid elimination from the system. And again, but interestingly here at this point, females do show significantly higher levels of ketamine when compared to the males. And if you're looking at the area under the curve or the AUC. If you look at this when dosed subcutaneously, again, it's a similar AUC levels. And again, females are showing significantly higher levels when compared to the males. But the levels are higher longer when dosed subcutaneously. It doesn't have this high Cmax that the intravenous administration does, but it does show higher levels at 1 and 2 hours afterwards when compared to intravenously dosed ketamine. The results are even more striking here with MK801. And here we looked at 3 different routes of administration comparing the male and the female rats. Again, when dosed intravenously, there was a significant difference between the male and female administration for the area under the curve, or the AUC. But this relative variation was much larger when dosed intraperitoneally, and especially when dosed subcutaneously, where the female rats were seeing 5 times higher AUC values for MK801 when compared to the male animals. Now, you'll remember the female animals were far more susceptible to MK801. If I had to give a reason, I would say it's this reason. There is just much more MK801 in the female animals, despite them being dosed at the same level. With this, I'm going to switch gears slightly into the neurotoxicology studies. For this, again, we're looking to mimic as close as we can the current antidepressant treatment for ketamine. And we're looking at Wistar rats, 12 to 14 weeks old, and 10 animals per sex, per time point, per dose. We have our negative control, which will just be saline, and then 4 doses of HNK at 12, 80, 120, 160 mg per kg. And we want to go as high as we could safely. And this is an intravenous infusion over 20 minutes. With ketamine, we're looking at 3 doses, 3, 10, and 20 mg per kg. And interestingly here, 20 mg per kg was as high as we could safely go with an intravenous administration of ketamine in female rats. At higher doses, 30, 40 mg per kg, we saw immediate lethality in some of the cases. So our animal use protocols limited us to up only 20 mg per kg. And again, we'll show our MK801 here as our positive control at 0 and 8 mg per kg. And this is going to be a subcutaneous administration. What we're looking for here is going to be vacuolization via H&E staining at 3 hours into 72 hours. We should, according to the literature, see that at 3 hours, and that should be resolved by 72 hours afterwards. We're also going to be looking for necrosis, both by H&E staining, but it's going to be quantitated for our purposes by fluorojade staining. And that should occur after the vacuolization in some cases, but it's not going to go away. It's going to be irreversible. And we're going to also look for 2 other markers of brain injury: increased IBA1 labeling, increased GFAP labeling. In the single dose experiment, as expected, our negative control was negative. We didn't see any animals with vacuolization, necrosis, or increased IBA1 labeling or increased GFAP labeling. Gratifyingly, at every dose of 2R6R H and K we tested, we didn't see any of these effects at all either. There was no vacuolization necrosis. Interestingly, ketamine also didn't show any of those effects, even when dosed at 20 mg per kg intravenously. We didn't see the vacuolization, we didn't see any necrosis. It's perhaps not entirely surprising because we needed up to 40 mg per kg subcutaneously ketamine according to the literature to see these effects, but still it is interesting to note. And our positive control, MK801, did show vacuolization in each of these cases at 3 hours, and that was gone at 72 hours. The necrosis was only present at the higher dose. At 0.5 mg per kg, we didn't see any necrosis in this single dose experiment. Looking at our multiple dose experiment, again, we're looking to mimic the trial as close as we can, and we're limiting the dose down to 12, 80, and 160 mg per kg hydroxynorketamine, and 2 doses of ketamine, 50 and 60 mg per kg. And here we're switching to IP dosing because we do want to see if we can push those levels higher and see any of the vacuolization that had been noted in the literature with ketamine. And we're also, once again, using our positive control MK801 here via subcutaneous dosing in female rats. In terms of the timing of this experiment, this is what it looks like up top. On day 1, we're giving them the first dose, and 3 hours after that, we're going to take a look at the first evaluation. On day 4, there is the second dose. On day 11, we're looking at dose 3, and on day 15, we're giving them the 4th dose. 3 hours after that 4th dose was the second evaluation, and then we're going to look again at 72 hours after that 4th dose. And again, we're looking for vacuolization via H&E staining, a necrosis via H&E and fluorojade, and increased IVA1 labeling, increased GFAP labeling. Once again, we see our negative control clean across the board with no vacuolization necrosis. And gratifyingly, we see 2R6R and K without any vacuolization or necrosis or increased IVA1 labeling or GFAP. 2R6R and K is a remarkably safe molecule within these experiments. Interestingly, we didn't see any vacuolization or necrosis with ketamine, even up to 60 mg per kg intraperitoneally. And we didn't see any necrosis or other signs of brain injury. And we did look, and it just wasn't there in this experiment. This is somewhat contradictory to some of the literature, perhaps, but it was something we felt we had to report. MK801, we didn't see as much vacuolization in this multiple dose experiment as we did in the first one. However, we did see quite a good deal of necrosis at the later time points, including at the lower doses in this multiple dose experiment, where we didn't see that before. We also see other indications of brain injury, including increased IVA1 labeling and increased GFAP staining, which wasn't present in the single dose experiment for either of those previous doses. This is suggestive that the multiple doses of MK801, even spaced out as they are, were producing more brain injury. And as an example here from the SI of the paper, just compare the GFAP staining. The top example here is our control experiment. And the bottom one here is at 0.8 mg per kg. You can see the increased staining present there and the increased darkness throughout. And this is what we're calling a positive hit for this experiment. So in terms of conclusions, 2R6R HNK appears to be safe from a neurotoxicity standpoint at up to 160 mg per kg, which is the highest dose we went into here. Ketamine also appears to be relatively safe at the doses and routes of administration tested. We didn't observe necrosis, increased IVA1 staining, increased GFAP staining. This does note that when we tried dosing ketamine at 30 mg per kg IV, we did note immediate lethality in at least a few of the animals. So it's not completely safe, but at the doses and routes of administration noted above, it did appear to be relatively safe. And we do note that the MK801 does cause vacuolization and necrosis, even at 0.5 mg per kg in those repeat doses. The last thing to note here is the pharmacokinetics may appear to have a major role here, especially in the sex-based differentials seen before in regards to the neurotoxicity. with that, just going forward, some things to consider. The ketamine levels drop fairly rapidly when dosed to rats. While MK801 has a much longer half-life. It's just around much longer. If potentially you were to somehow extend ketamine's half-life to make it so it lasted much longer in the system, like MK801, it may be worth revisiting these neurotoxicity studies to see if it really is that length of time that the NMDAR receptor antagonist is in the system that is causing this only lesion toxicity. So with that, I want to thank you all for coming. These are the acknowledgments. Many people worked on this. I've been told to keep this short. And I want to thank my sponsors for having me to present. So thank you, everyone.
Thank you. Thank you very much, Pat. It's such a data-rich paper and work, and give us something to think. And I understand there's also a lot to take in. However, I really encourage you to type then any question that comes to your mind into the Q&A, so then we can escalate them to Pat. But in the meantime that you're all thinking of it, I have maybe one or two questions myself, if you don't mind me kicking in. But so one would be, and I see that I think also Rupert has already some question, but I think in the study, for example, in the multiple dose neuropathology results with the intraperitoneal administration, it's I think it was like administered as a bolus, right? It wasn't like over time. And for what you were saying before, since the pharmacokinetics of the drug seems like to have this major role, do we have any reason to think that if we extend the area under the curve, basically with a longer infusion time, that information may change?
So it's definitely a good question. Not having run the studies, I can't say anything for certain. It is suggestive that if you extended it or you gave repeat doses at 1 hour, 2 hours, 3 hours, you might extend it long enough to see the neurotoxicity. And again, these are in rodents, they aren't in anything larger. So it's very difficult for me to parallel this to human studies. And it's definitely an area I would look at more if we have the opportunity to. The other thing to consider is typically these dosing, this is the highest dosing level we could get at without killing the rats. Usually when dosing things like this clinically, you don't do that. You go to a much lower dose. So it's something to consider there, that if the dose is low enough, you may not hit that threshold. Right.
Yeah. I think it's usually maybe around like 10 to 30. Right, in the paralleling to animal, like when they study like this antidepressant effect of ketamine, where I think you went up to 50 or 60.
Usually it's 10 is most common from what I've seen for the antidepressant studies. That's in mice typically. Yeah. Rats, I believe, is about the same, that there are some differences there between the animals. So.
Right. So I think we have a question from Rupert.
Well, I'll just ask it, thanks. So can you just tell us a bit about the biology of Olney lesions and how that progresses to necrosis? And is this in any sense related to excitotoxicity, or I mean, what's going on?
So I would love to go further into depth into it. We didn't run any of those studies to exactly nail down what's going on. There are some studies that suggest that these only lesions form specifically in the retrosplenal cortex and posterior cingulate of rats. But when you have these antagonists directly administered to the posterior cingulate and retrosplenal cortex, you don't see the only lesion formation. It's potentially something going on elsewhere in the brain that's forming some sort of toxicity. So really, that's all I could potentially say on it at this point. Perhaps we can get into it more later during the discussion.
And can you just remind us, for those of us who've got poor memories, you did at the beginning of the talk, you explained some of the literature that suggested that there were only lesions with ketamine. How did they differ from in terms of the experiments to the work?
So the major difference is they were dosing ketamine subcutaneously. We didn't want to do that originally because ketamine typically isn't dosed subcutaneously in humans. It's typically dosed IV. So that's really where we want to start. We also went IP, and there's a couple experiments that look IP in the literature, and it's suggestive that when it's dosed IP in rodents, you can see it. We didn't. There are some minor strain differences, and it's so narrow a window. As I demonstrated, when their ages make a huge effect, the gender makes a huge effect. So that's really part of why I want to run the PK studies, to see if we can narrow down exactly what is needed.
Anything known from non-human primates?
There are examples, one example in canines that demonstrated it with an experimental NMDA receptor antagonist. There's no full study on it. It just came up in a review as, a single paragraph. So it was seen there. In terms of humans, we haven't observed it, but again, that's going to be almost very, very difficult to find in humans. So in terms of monkeys, I haven't seen anything. So.
Thank you.
So we have some question from our audience, but maybe I can read this to you. What's the sex difference in vacuolization with ketamine observed with S-ketamine or racemic ketamine?
It was racemic ketamine in these studies.
And in the ketamine groups, any immediate behavioral difference, for example, clinical observation in male versus female rats?
So when we dosed ketamine, we dosed it exclusively in female rats. So I can't give you a gender difference there. When we dosed 2R6R H and K, we did use male and female rats, and we didn't observe any behavioral differences there.
And do you think that the rat strain like Wistar or the timing of sampling 3 hours and 72 hours have had a role in the lack of effect for ketamine?
So the sampling does play a role in the terms of the time. Again, that vacuolization is gone usually by 24 hours afterwards. So this was definitely in the literature. Strain may play a role. Especially if you're talking about narrow differences in pharmacokinetics, which you may be doing with ketamine. So there was that one example with the Fisher 344 rats versus the Sprague-Dawley rats. And there were slight differences there, but they were there, where the Sprague-Dawley rats were somewhat more sensitive.